Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Phase 3 trial of Cetuximab with continuous or intermittent fluorouracil, Leucovorin, and Oxaliplatin, Nordic Phlox, versus Phlox alone in first-line treatment of metastatic colorectal cancer, the Nordic 7 study by Kel Magnavit et al. My name is Dr. Michael O'Connell, and I am Emeritus Professor of Oncology at the Mayo Clinic and Associate Chairman of the National Surgical Adjuvant Breast and Bowel Project in Pittsburgh, Pennsylvania. My oncologic specialty is medical oncology, with a podcast, No Advantage to Combining Cetuximab with 5-FU, Leucovorin, and Oxaliplatin in Metastatic Colorectal Cancer. This 3-arm randomized clinical trial evaluated 2 concepts in the first-line treatment of 571 metastatic colorectal cancer patients with a bolus Nordic Phlox regimen. First, to determine the value of adding cetuximab to the chemotherapy regimen, and second, to compare continuous administration of treatment with a stop-and-go administration schedule. The primary endpoint was progression-free survival for the cetuximab comparison and overall survival for the stop-and-go approach. Mutation analysis for KRAS and BRAF was carried out on the majority of paraffin-embedded tumor specimens. The study was well conducted with independent validation of mutation status, thorough and appropriate statistical analysis, and thoughtful discussion. As has been shown with different treatment regimens in previous clinical trials, the stop-and-go approach using Nordic Phlox combined with cetuximab induction followed by single-agent cetuximab maintenance therapy did not compromise overall survival compared with continuous administration of the same induction regimen. This data further supports the use of stop-and-go in clinical practice. The more provocative result was the lack of benefit in adding cetuximab to the Nordic Phlox regimen. There was no significant improvement in progression-free or overall survival and no improvement in objective tumor response rates, regardless of KRAS status. These results stand in stark contrast to the much larger CRYSTAL study comparing irinotecan, 5-FU, and leucovorin, the FOLFIRI regimen, with or without cetuximab in first-line metastatic colorectal cancer. The CRYSTAL study indicated a significant benefit for the addition of cetuximab in patients with KRAS wild-type tumors. How can these divergent results be explained? One consideration is insufficient sample size in the Nordic 7 study to evaluate treatment benefit according to KRAS status. When the goal of evaluating cetuximab according to KRAS status was added during the conduct of the study, the sample size was not increased to maintain statistical power in each of the subsets. There were only 45 and 46 patients with KRAS wild-type tumors, respectively, in the primary pairwise comparison. It is possible that some degree of benefit from cetuximab could have been missed. On the other hand, it is possible that the specific chemotherapy drugs combined with an EGFR inhibitor may be very important in the activity of the combination. For example, decrease in cellular proliferation, which is characteristic of EGFR inhibitors, inhibits the cytotoxic effect of 5-FU in preclinical studies. Since the activity of oxaliplatin in colorectal cancer is thought to require interaction with fluorinated pyrimidines such as 5-FU, one can speculate on a lack of synergy between cetuximab and FLOX, particularly for patients with KRAS mutant tumors. Irinotecan, on the other hand, has single-agent activity in colorectal cancer independent of fluorinated pyrimidines. This may be a mechanism to explain the different clinical outcomes. Consistent with the lack of benefit of adding cetuximab to an oxaliplatin regimen in the Nordic 7 trial are the negative results of adding cetuximab to capecitabine and oxaliplatin in the British COIN study. It should be noted for completeness that a subset analysis of the randomized phase 2 OPUS study suggested benefit for patients with KRAS wild-type tumors treated with cetuximab and FOLFOX, although these results cannot be considered definitive. Also to be considered are the results of intergroup N0147, which evaluated the combination of cetuximab and FOLFOX chemotherapy in KRAS wild-type, stage 3 colon cancer patients in the surgical adjuvant setting. Cetuximab plus FOLFOX was no better than FOLFOX alone. In conclusion, I agree with the Nordic 7 authors that it may be questioned whether cetuximab and oxaliplatin are good partners in the treatment of metastatic colorectal cancer. Future clinical trials of targeted agents in combination with chemotherapy should be based on solid preclinical observations regarding interactions of the specific chemotherapy agents and targeted drugs. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.